Alright, so we're picking up from where we left off. We were talking about glenohumeral joint sprain and dislocation, and certainly subluxation is also not a possibility. We talked about how this acute injury could turn into the chronic problem for a lot of people, especially if the first dislocation occurs at the younger age. Depending on the direction that it goes, whether that's anteriorly or posteriorly or inferior, they might hold their arm a little bit differently. You see a bit of a different obvious deformity. One key thing here is you can actually palpate the humeral head if that humeral head is still out of place. So this is something that you're not really supposed to be able to feel if everything is in place, but when the humeral head slips out of the place, sometimes it becomes palpable, and that would indicate a good glenohumeral joint dislocation. They'll typically will be unable to move their arm. They might report the popping episode. They might literally say, my shoulder popped out of the socket, or I heard a loud pop in my shoulder. Muscle spasm is also very common. I've seen anything from deltoid spasm to upper trap to levator scap to rhomboid spasm to lats. So anything of that nature is a possibility. If it's a chronic though, sometimes they can actually voluntarily pull that ball out of socket back and forth, so it may or may not be that painful, especially if it's chronic. They typically complain the unstable feeling of the joint. Neurovascular finding depending on a case. If they happen to stretch the nerve with the dislocation, or the humeral head is putting compression over the artery vein, something like that, maybe you see some numbness, tingling, ischemic kind of a pain episode. You can use any kind of instability test that we went over in class to confirm the presence of a dislocation. First time shoulder dislocation should always be treated as a possible fracture or labrum tear, so you should consider immediate referral. Now, Hill-Sachs lesion. This is a fracture to the humeral head and commonly associated with the anterior GH dislocation. Let me show you. Here's the head, here's the socket. When you pop this and then dislocate this humeral head anteriorly, what's going to happen is going to roll. Okay, so this particular part of the humeral head come in contact with the edge of the glenoid, and what people would often experience is this edge of the glenoid fracturing the humeral head like this. So when everything is back in the socket now, what you end up with a nice fracture over the humeral head. You can see that in this picture while it's still out and everything is now back in place, and then what you have is this nice part of the posterior humeral head that's almost being eaten. And similar fracture could occur with the posterior GH dislocation. This one is known as a reverse Hill-Sachs lesion. So again, similar picture that we're looking at, glenoid and the head of the humerus. When it rolls back and then dislocate posteriorly, this anterior aspect of the humeral head is going to come into contact with the posterior edge of the glenoid, and you will experience the fracture. So when everything is back in the socket again, you will still have a fracture over the anterior humeral head. Now, this fracture itself is often asymptomatic, but just because you have this fracture over here and a lot of chemical mediators that's going to be released in that area, that can facilitate the early degeneration of the glenohumeral joint itself. And that could potentially become long-term disability in the shoulder. Moving on to the labrum tears, we have three major kinds: slap lesion, Buncard lesion, and posterior labrum tears. Posterior tears are often sometimes referred to as a reverse Buncard lesion. Those names will be determined based on where the tear is happening. So let me orient you first. We're looking at the right scapula. We're looking right at the right glenoid fossa, and then here's the glenoid rim, actual cartilage. So the labrum is here. What I see here is the coracoid process, spine of the scapula, and the acromion process should be almost right around here. When a tear occurs on a superior portion of the labrum, right here, this is what we call slap lesion. Okay, so this is the anterior aspect of the shoulder, this is the posterior aspect. What you see is this superior tear extending from the anterior surface to posterior surface. This is known as slap. The tear that's happened over the anterior inferior surface is what we call Buncard lesion, right over here. If the tear occurs over the posterior inferior surface, we call that as posterior labrum tears. So exclusively based on the location of the tears, we have three different names. It is possible for people to develop more than one tear. Maybe I started out with a slap lesion and that tear started to extend towards the posterior aspect of the labrum. Maybe now I have a combination of those two, and sometimes they start to extend. So for example, this particular tear extending from slap all the way down the posterior aspect, people might call that as 270 degrees of tear, combination of slap and posterior. This concept might come in handy if you are to look at somebody's labrum as a clock. Okay, so some people might say, okay, slap lesion, anything from 10 o'clock to 2 o'clock, we call that a slap lesion. Barncard is typically from 3 o'clock to 6. If we're looking at the left glenoid, it's going to be from 9 to 6. Okay, posterior tear typically from 6 to 9 or 6 to 10-ish. Okay, so if these numbers, if it's helpful for you to remember, you can certainly use those numbers. So let's start with the slap lesion. SLAP, S-L-A-P, stands for superior labral tear, anterior to posterior. This tear is happening right at the insertion point of the long head of the biceps. So you can see this tendon wrapping around, inserting on the supraglenoid fossa. And this is where the tear is happening. Typically, when you have some kind of a glenohumeral instability, that would create an extra translation of the humeral head, and that would create the constant extra pulling from the biceps tendon, possibly leading to the slap lesion long term. So GH instability is often known as a precursor of this particular tear. While other labrum tears could occur as the results of the trauma, slap lesion is almost always a chronic injury. And I like to use this analogy of pulling the grass. Insertion point of the long head of the biceps is firmly attached to the part of the glen. If you are to experience any kind of a tear over there, it's like you playing in the backyard and trying to pull glass out of the ground. If you are to try to do it with just one force, one motion, you're typically not going to be very successful. What you end up doing is probably just ripping the glass. If you actually want to pull grass out of the ground, what you're going to have to do is you have to pull in a couple different directions, wiggle a little bit, take your time, and get your ground nice and loose, and you can pull the entire grass off completely from the ground, looking like this. And that's what the slap lesion is. In order for you to experience a tear over here, over the slap lesion, you're going to have to take your time and wiggle around, and that is why glenohumeral instability is known as one of the precursors. Because when you have an instability, it means you have a little bit of kind of a loose ground to play with. And if you wiggle it for long enough, then you can actually end up pulling the grass off the ground. And that's why this tear is very common among baseball pitchers, because every time they pitch, they're actually wiggling the glass. There are a couple different ways for you to classify slap lesion. Snyder classification is very common. You can classify these tears from type 1, type 2, type 3, and type 4. Type 1 is not necessarily tear, it's more of a degenerative fray around the long head of the biceps tendon. That's what this LHBT stands for, long head of the biceps tendon. And 2, at the insertion point of the long head of the biceps tendon, you actually start to see a nice tear over here and a avulsion of the actual labrum. 3, you will start to see the displacement of the torn end, looking like a bucket handle tear, almost very identical to the bucket handle tear of the meniscus in the knee. But the long head of the biceps itself is intact, still attached. And type 4 is very similar with type 3, but with a displacement actual tear in the long head of the biceps. So looking at exact same thing, type 1, just some flares, scarring of some tissues around it. Type 2, you start to see that avulsion of the labrum from the head of the long head of the biceps. And type 3, you start to see some nice displacement, bucket handle tear, but the tendon is still there. And type 4, you start to see the tendon itself coming off with the bucket handle tear. And Dr. Morgan, about 8 years later, he said that, well, we can maybe add a little bit of a subtypes for the type 2. If you see more bacteria in the anterior, we can say type 2 anterior. If it's posterior, then type 2 posterior. And sometimes you can have combined type 2 tears. And some other doctors said that, well, it's not good enough. Let's go ahead and add type 5, 6, and 7. So type 5 here, is a combination of slap lesion as well as the Bunkard lesion extending all the way into covering all anterior surface of the labrum. Type 6, you see a little bit of unstable flap there up the labrum with a long head of the biceps tendon tear. And type 7, you have slap lesion that's extending anterior and then now inferior and then start to affect the joint capsule. And another classification, this doctor wanted to add type 8, 9, and 10. Type 8 will be the combination of slap and posterior tear. And type 9 is going to be all the way 360 degrees, and then type 10 tears start to extend posterior inferiorly. Now, is it just me or just people like to keep adding things? Okay, these now doctor wanted to add some what about the cartilage involved in the loose bodies? We need to come up with all these classifications as well. Now, I might have to say that's a little bit too much for us. If you're going to be a specialist in the shoulder and want to become an orthopedic surgeon, you probably need to know them all. But most of us are just trying to get into the field of athletic training and physical therapy, occupational therapy. So I would say, let's just go back to the basics. I just want you to know type 1 through 4. Type 1 through 4, and that's all. Okay, just know that there's some other classification that's out there, but the only thing that I want you to know for the test and the quiz is type 1 through 4. Now, clinical presentation of the slap lesion is very inconsistent. They'll typically complain pain around the shoulder, but they typically cannot pinpoint. Sometimes they'll point more on the top of the glenohumeral joint. Sometimes they point anteriorly, posteriorly. So it's very difficult for us to say this is what you're going to be looking for. Most likely they also have something else with it. Okay. Again, this is kind of a wiggling injury. So if they have associated, say GH instability or rotator cuff weakness, rotator cuff tendinosis, maybe you can find those evidence as well. They would often complain clicking, catching, popping sensation in the shoulder with the motion. Internal rotation and horizontal adduction is often limited. Again, you might find something else that led to this particular condition, maybe poor posture, poor scapular position function, something like that. Arthroscopy is the gold standard. If you can just open it up and then put the camera inside and then see the tear, then that'll be the best way to diagnose this condition. But other options, X-rays are not going to be helpful. MRI is often not very helpful neither. MRA, using the contrast to really signify the tear, that is the one that we often use in terms of diagnostic imaging. And there are a couple different special tests for you to use. We're going to go over that in the next lecture. Bunkard lesion is very, very difficult to diagnose, mainly because there's no special tests that are designed specifically to diagnose Bunkard lesion. You can try to use some special tests that are designed more for slap lesion, and maybe you might be able to find some positives there. But other than that, you might need to just rely on the patient's chief complaints and sign of symptoms that they presented. Pain and maybe a little bit of unstable feeling over the anterior-inferior aspect of the GH joint. For the posterior labrum tear, there are two special tests that we can use to detect this particular injury. Kim test and jerk test. So you might actually need to remember these two tests. And the special test that we went over to detect the posterior instability might also be useful, because when you shift the the humeral head posteriorly back in the socket, it might irritate the posterior labrum tears. But that theory is never tested, so we do not know if the posterior apprehension test and drawer test are going to be any useful to diagnose this condition. I would personally like to use it just in case. But if anything, remember to use these two tests to diagnose, roll out the posterior labrum tears. In the next lecture, we're going to be talking about specific special tests that are going to be useful to maybe roll out these